Welcome to our weekly Zoom news conference. I'm Sandy Close, Director of Ethnic Media Services. Today we present a year in review of the COVID-19 pandemic, which has taken 800,000 lives in the United States and 5.3 million worldwide. Even as we grapple with the lethal Delta variant, we now face new challenges from Omicron. Speakers today will provide an overview of where we are in the pandemic and what 2022 may hold. Our presenters include several familiar faces who have informed us throughout the past 21 months and to whom we are deeply grateful. They include Dr. Tung Nguyen, Stephen J. McPhee, Endowed Chair in General Internal Medicine and Professor of Medicine at the University of California, San Francisco. I'm sorry if I mispronounced that. I really meant to say Dr. Tung Nguyen, Stephen J. McPhee, Endowed Chair. We want to get the title right. Dr. Ben Newman, Chief Virologist at the Global Health Research Complex at Texas A&M University. Dr. Roshni Matthew, a pediatric infectious diseases physician and co-medical director of infection prevention and control at Stanford Children's Health. Dr. Dali Fan, University of California, Davis Health Science clinical professor and volunteer vaccinator at California North State University in Elk Grove, California. And Peter Barduk, Director of Public Citizens Access to Medicines Group. We have a really splendid panel. Today's news briefing, we ask our speakers to speak slowly so our interpreters in Spanish, Mandarin, and Korean can accurately reflect your presentations. We urge media colleagues to enter questions in the chat box. We hope our speakers will monitor the chat box and respond via chat throughout the conference. We will send expanded bios and a video of the conference later today. And in 2 to 3 weeks, it often takes that much time, we will send all our speakers sampling of the coverage today's briefing generates. So now I turn today's conference over to EMS Associate Editor, Sunita Sarabji. Thanks, Sunita.
Thank you, Sandy. We start our briefing today with Dr. Tung Nguyen, who many of you know from our previous briefings. Dr. Nguyen, before you start your presentation, I would like to ask you, when you joined us back in March of 2020, did you ever think that we would get to this point in the US where we are now seeing 800,000 deaths?
No, I would say that if you had asked me then about when we think that we would have this pandemic under control, I think like many people, I would have said this year, but probably in the fall. I think things have not gone the way we wanted to say the least.
Okay, please start your presentation.
Great, thanks everyone. Thanks for having me back. We're almost at the 2-year mark of the COVID-19 pandemic, and suffice it to say, I think we're a long way from the end. Worldwide, we're at 270 million cases, and as Sandy said, 5.3 million deaths. The United States had over 50 million cases and over 800,000 deaths. In other words, we account for about 1 out of 5 cases and 1 out of 6 deaths in the whole globe, which is way higher than would be expected for our population, which is indication of how badly we're doing. More Americans have died from this pandemic in 2 years than died in all the wars of the last 120 years, including World War I and World War II. Because sometimes that number 800,000 doesn't register. I do also want to remind you that of the 50 million who did survive COVID, they're not out of the woods, as we don't know the long-term consequences of COVID, though we do know that many do end up with persistent health issues. The next wave is here. We have over 120,000 new cases a day now, about a 40% increase over the prior 2 weeks, and about 68,000 hospitalizations, an increase of about 21%. Compared to last December, this is about half of what it was last December. But I don't think that's good news. I think we're just earlier in this wave. There are some people who are projecting that we'll get about 300,000 cases a day in the next few months. Our healthcare system in which I work has been stretched to the breaking point several times already during this pandemic and is totally poorly equipped to deal with this wave. Many healthcare providers who are my colleagues are leaving the healthcare system now, and those who are staying are burnt out and depressed. And this matters to all of us, not just people who get COVID. People with other illnesses are not and will not be getting the care they need in a timely manner. So even though someone is protected against COVID vaccination, they can get sick.
Gwen, I'm so sorry. One of our interpreters asked that you just slow down just a bit.
No problem.
Thank you.
So even though someone is protected against COVID with vaccination, they can still have a heart attack, a stroke, an accident, and then the healthcare system is overwhelmed with the number of COVID patients, and they will suffer, and their family will suffer. As of October, before the Omicron variant, the risk of getting COVID among the unvaccinated was 5 times higher than those who were fully vaccinated. And the risk of death was 13 times higher for the unvaccinated. Some good news, 61% of the population is fully vaccinated. There are still some disparities in receipt by race and ethnicity. Black Americans are still the least likely to be fully vaccinated, while Latinos and whites have similar rates, and Asians have the highest rates. The gap, though, between Black and Latinos and whites have closed significantly, partly because Black and Latinos are doing better with vaccination, and whites have sort of reached a plateau in terms of the vaccination rates. The vaccination rate among those who are 65 and older, who account for about 3/4 of the deaths so far, is 87%, which is really good news. And among those 12 and older is 71%. So a lot of the unvaccinated are those who are much younger, obviously. The bad news is the effectiveness of the 2 doses of the Moderna or Pfizer vaccines are significantly reduced against the Omicron variant. So now we're not only have to assess the rate of full vaccination, we also assess the rate of booster receipt. Only 31% of those 18 and older and 53% of those 65 and older have had their booster shot. On the treatment side, the new Pfizer COVID medication Paxlovid, through a press release, we haven't seen the actual science yet, is about 90% effective in preventing severe disease and death in a randomized controlled trial. But it wasn't great at reducing symptoms. And again, we don't know what it would do for the long-term health effects from those who survive COVID. So it's not a panacea. My co-panelists will be talking more about Omicron, but we do know that the more cases we have, the more the virus can mutate. And the more mutations there are, the more likely that one will come that escapes the current vaccines and treatment. So that is why we have to really continually emphasize the importance of the public health approach of getting everyone vaccinated, but also making sure that people wear surgical or N95 masks around others, and having easy access to rapid COVID testing. I'll finish by saying that the misinformation and disinformation around COVID prevention and treatment have been very damaging and deadly. We need to fight this rapid viral spread of COVID-19 with the rapid spread of good information that will protect our people. One of the issues that I've learned from working with communities recently is that the rapid changes in the science, the information, is confusing people. And also perhaps increasing mistrust if what the scientists and the government is saying changes week to week, that is certainly a reason why people end up distrusting the information. We have to be persuasive in an honest way. Rapidly changing information and recommendations are due to rapidly effective scientific monitoring and responses. That's what's going on, not a negative. So we should expect recommendations and policies to change. I am hoping that ethnic media journalists are doing everything you can to get information out accurately and with humility to your communities in ways that you know work best. Thank you.
Dr. Nguyen, thank you. Our first question comes from Henrietta Burrows. Henrietta, could you please ask your question?
Thanks so much, Sunita. I've heard that the vaccines waned after about 6 months. So how long do you think the latest booster shot will last? And will we need new boosters for each variant?
I think there are those who are probably more qualified to answer this than me, but I think the answer is that we don't know yet. Certainly, the booster helps against the current Omicron variant. My anticipation is that we will probably be getting more boosters in the future. I just don't know the exact. The science is not there yet to say so, but I think we should expect multiple vaccinations against COVID as we go forward.
Sandy asks a question: what constitutes good information, Dr. Nguyen?
Again, I find that people respond better when we are humble in terms of what we say. We say, this is what we know for now. Things may change. We want to treat people respectfully, right? And I think that's the best way to do it. Being too definitive is not helpful. Being sort of negative or stigmatizing is not helpful. Everyone's learning. This is a learning process for everyone, including those who haven't learned that they need the vaccine.
Absolutely. I have a question for you. The CDC just put out an alert about the Johnson & Johnson vaccine, saying that there may be side effects associated with it and that it didn't recommend it for a booster. Johnson & Johnson has been used in a lot of community health clinics, pop-up clinics, etc. So we've given a population a vaccine which in retrospect has turned out not to be as effective as the Pfizer and Moderna. Could you address that?
Yeah, I think again, this is a dynamic process that changes all the time. So I don't think, for example, we want to say that somehow people were given the less effective vaccine. We were trying to get everyone covered as fast as possible, and there were supply issues with Pfizer and Moderna. And so even the limited efficacy of the J&J vaccine was still good. It was pretty good, and it certainly beat not getting the vaccine. So for the time that we had then, it was appropriate. I think now we know that those who had J&J vaccine should get a different vaccine for their booster. So I think we need to reassure people and not make it into sort of a mistrust situation where somehow our community got the worst part of the deal for whatever reason. Like this is a rapidly moving situation. We wanted everyone covered as fast as possible. The vaccine was effective. It was not ineffective. And so now we just need to make it more effective by giving a more widely available vaccine.
There are a couple of questions which need a bit of clarification, and they are good examples of misinformation. Fatma Bakit asks, why do you ask people to take a booster vaccination knowing that it is for the elderly 65 and up? And that is not true. Could you address?
Yeah, everyone should be getting a booster vaccine. I think the current recommendation, I believe, is 16 and older.
Right.
I think the recommendation came, and we know that we need it for the Omicron variant. So everyone should be getting the booster.
And another issue of misinformation: is it true that if you got the COVID vaccine, you will have a higher chance of getting Omicron?
No. That is absolutely true. As a matter of fact, if you get the booster vaccine, you have a lesser chance of getting Omicron. So,
Dr. Nguyen, thank you so much for addressing our panel once again. We really appreciate it. And, I'm hoping that we don't have to see you in the next year. I'm hoping that somehow we're going to get this under control. So have a happy holiday. We move on next to Dr. Ben Newman. Sandy has already introduced you, Dr. Newman, but I would like to ask you a question before you start your presentation. When you last were with us, I believe it was in September, was Omicron even on the radar at that point?
No, last September, Omicron was somewhere on the very long branch that connects it to the viruses that we know. And we don't know if this popped up inside one person with a long case or if this was just mutating somewhere out of the sight of the major sequencing operations. There's maybe no way to tell at this point.
Interesting. Please start your presentation.
Sure.
Thank you.
Hello and thanks. Yeah. Okay, so I think the message I'm going to try to get across is that we are in for the fight of our lives with Omicron, but let's keep calm and see this thing through because we have the tools to be able to solve this. As Dr. Nguyen just said, it's very much a case of the vaccines and masks definitely work, and these are our way out. First, on the variant. So Omicron appears to be bad. Everything that we're reading now shows that it grows well and it spreads well. I would say treat some of the modeling studies with some skepticism, or at least that's what I do, just because they're modeling something where they don't know exactly how the virus will respond, and any modeling study is most accurate in the short term rather than the long term. So I know we would all like to see a modeling study that shows that the virus will go away very soon, but I am very skeptical whenever I read something like that because I don't think we can predict that accurately at the moment. Omicron has already split and is now considered as being 4 sublineages of the old Omicron variant. And each of these are being tracked and are spreading. At least anecdotally, they are spreading in the community around me and probably also in the community around you. There have been some studies looking at how quickly the virus grows. I would say those studies, the ones that I have seen so far, do not look as though they are particularly robust. For example, there's one from Hong Kong University that found barely detectable levels and small differences between levels of different variants, but it looks as though their cell culture system may not have been working very well on that. So I don't know that those numbers are reliable. But at least on the small samples that we're seeing locally, the virus does not appear to grow any less than Delta did. The numbers we're seeing are a little higher, but they are small samples. And so I would not say that they are categorically higher. And we do have several papers from last year and this year that show that when there is higher viral load, a higher amount of virus in the lungs, there's a greater chance of symptoms, of hospitalization, and of death. So any reports, however hopeful, that predict that Omicron is going to be mild somehow, kind of fly in the face of the science that we know. And I would also treat those skeptically. I would say do not underestimate Omicron. So the good news is that quantity can trump specificity in terms of our immune response. We don't necessarily need an Omicron-specific booster yet, although that will be very nice when we get one. And we probably don't need a booster for every variant, but Omicron is different enough and distant enough on the particular part that sticks to the cell that it would be wise to have additional protection against this one. All right. Second point, I would say, again, echoing Dr. Nguyen's statements, some of the terms that I would try to get away from are fully vaccinated, for example, just because we know how many doses a person has had, perhaps, but we still don't know what full vaccination looks like. No scientist can tell you how many doses are going to provide lifelong immunity, if there even is a number. And so I think that gives a false sense of security. And I think that is at least partly behind what we're seeing happening around the world with people who think that the vaccine is enough of a shield, or that prior infection is enough of a shield to protect them, and are finding out that that is not always the case. Yeah. I think you can also draw a straight line between some policy decisions and political decisions that have allowed the virus to grow in certain populations and at certain times, and the situation that we are in today. We have good evidence now that even very young children can be infected as much as the older people. And getting rid of COVID means stopping every single part of the reservoir, which is the group of people who are capable of catching and spreading the virus. Yeah, this is not a time for policies of appeasement to COVID-19. I would say also we should avoid, if possible, using any data which leaves out any group of people. So by that, I mean, I was reading today something from the UK, and they were showing that they had nearly 90% of people over 15 who had either had COVID or had had some vaccination. But it left out the people under 15, and we do this again at our peril. This has been one of our collective blind spots throughout COVID-19. And time and again, it has come back to bite us. And I think the last thing is that the pills that are out there are like a good offense. They can fight the virus when it's already inside of a person, but they provide no defensive measure. It is only the vaccines that can actually prevent infection and prevent spread. And the ugly fact is that most of us, if we get this virus, we'll spread it to someone that we know and someone that we love before we even know that we are infected. This is how we have a problem of this size right now. So, yeah, I think we can build on the vaccination that we've done. I wouldn't think of vaccines as somehow shortchanging us if they don't do everything. It's just like going back for another helping of ice cream or something. A little more is nice. Yeah. And it's okay. We can build on what we have, no matter where that immunity has come from. And I think it's essential that we do. So, yeah, that's all. Yeah.
Thank you so much, Dr. Newman. Carlos Matias has a question for you. He asks, how many new variants, and I think that's a question that we all have, how many new variants may arise hereafter? Is there room for hope to live again in a COVID-free world? I think you had thought that when you last came on, that this was not an endemic, but it was going to be a pandemic. Could you please address Carlos's question?
Yeah, the number of variants depends on the person classifying them. There is no hard and fast definition. We break the virus up into groups that seem useful at the time. Although there are general trends with large groups of these viruses that I think have some meaning. There isn't a variant out there that we can't stop. But what I would say is that for SARS coronavirus 1, I think we get only about 1% of the antibody protection that we get against SARS coronavirus 2 with our current vaccines. So those require different vaccines. With Omicron, we're at about 2% of the protection. So I think this is probably distant enough that we need another vaccine, if that's where we're heading with this question.
Absolutely. I would like to ask you a question about global vaccine equity, which Peter will address later on. But given the fact that we've identified Omicron in South Africa first, the Delta variant in India first, the P1 in Brazil first, What does this say about the need for global vaccine equity? We're talking about some of the developing world in which these variants have been identified. Do you think we need to ramp up our global vaccine equity effort?
This is like one of those movies where humans have to fight against an alien invasion. And the nice thing about those movies is that we all come together and everybody pitches in and we always end up winning in the ones that I've seen.
Right.
That's the way out. And that's probably the only way out. If anyone is susceptible on this planet, the virus will hang around and it will eventually spread back and, come. If you close the front door, it'll come in the back door. So it's very much, we're all in this together, and that is part of it. Vaccine equity is our way out.
Absolutely. I'd like to have you address one last question from Henrietta Burrows. Henrietta? I can ask the question for her. Were chickenpox, smallpox, and polioviruses, how is it that they did not mutate, or did they? That's an interesting question.
Yeah. Oh my gosh. Yeah. A proper answer would go into a thing called quasi-species theory, which I don't think we have
a minute for. Yes.
Yeah. The idea is that some viruses find themselves in a position where they can make a lot of little changes and suffer relatively small consequences. For other viruses, they find themselves in a position where they are barely holding it together and any change is catastrophic. So something like polio was very much in that situation. It's kind of limited in the ways that it can change, because the part your immune system sees is also a fundamentally important part that's holding the virus together. And so there's a limit to how it can change. With smallpox and chickenpox, we have very good vaccines that actually stay in your body for the rest of your life. And that's something that we don't have and may not be able to have against COVID-19, just because of the type of virus this is and the places where it grows. So this is a virus that we can knock out with very high levels of vaccination right in a row and just create a sort of a firewall that way. But it's probably not one that we can vaccinate a little bit here and there and expect a good outcome.
Thank you. One final question. Are there variants of concerns that we as reporters should be aware of that you expect to see in the next? I know you answered this a little bit with Carlos, but if you could just amplify your response.
There's a somewhat Omicron-like variant, just in that it's a very long branch that I believe came out of the Gabon. That's one that I'm watching, certainly. But with any of these variants, there are lots of things going on with the virus. And until you see a real cluster of viruses starting to spread on any particular branch, there's really no good reason to pay extra attention to that. I would say people like me can watch those, but when we get a cluster, that's when it's wise for everybody to pay attention.
Thank you. There's a question from Khalil, but I believe all of the panelists can answer this question. On a policy issue, can the panelists speak to the international right of countries to dispense with patents to produce the current variant vaccines? I'm sorry, is this not what occurred during HIV/AIDS? Khalil, that's an excellent question. Oh, Peter says that he will speak to this towards the end. Shall we, are you all planning to stay on for the end of the conversation, and perhaps we can address it at that point? Terrific. We'll move on. We next introduce Dr. Roshni Matthew. Dr. Matthew, welcome. Dr. Matthew is going to speak about the pediatric response to COVID. Thank you so much for joining us.
Thank you so much. So I will be just paying attention to the pediatric COVID situation in the US primarily. So just a few questions that were sent to me, and I'm just going to answer those here in the beginning. So of all the COVID infections in the US, the pediatric contribution at this time is about 23%. When I say pediatric, I mean less than 18 years of age. The pediatric curve for prevalence of COVID has generally mirrored the curve for adults, but the overall pediatric proportion of cases have increased recently compared to earlier in the pandemic. And that could be explained by the fact that the vaccine approvals occurred earlier for adults. Pediatric hospitalizations and deaths due to COVID thankfully remain rare. Just to give an idea, approximately 1% of the 7 million pediatric COVID cases have required hospitalizations, and about 660 pediatric patients have died of COVID in the US. So some of the positive aspects that have come more recently is that in May 2021, the FDA and CDC approved the Pfizer vaccine for the 12 to 17-year-olds. And then more recently, in November 2021, they approved use for 5 to 11-year-olds. So a large proportion of pediatric population are now offered the protection older kids and adults have had for a while. Now for the next group of pediatric patients, which is the 2 to 4-year-olds and the 6 months to 2-year-olds, enrollment and trials are currently ongoing. So the results of these are not yet known, and the timeline for FDA and CDC approvals also not known. Now, in terms of boosters, the latest recommendation qualifies everyone over 16 years of age to get the booster 6 months after their mRNA vaccine. So the role of boosters is compelling with now early data that is emerging with regards to protection against Omicron variant. And the CDC strongly recommends that everyone who qualifies for a booster receives it. With regards to vaccine safety, so since the original data of the trials of Pfizer and Moderna came out last year around exactly the same time, I believe we are going through the 1-year anniversary right now, we now have real world experience with millions of people already vaccinated. Overall, vaccines have been found to be safe and very effective at preventing hospitalizations and death from COVID. And as a pediatric doctor, the adult data on safety and effectiveness is a great assurance and a strong reason to protect every eligible child with the vaccine. And just also to reassure, there are several safety monitoring processes that have been in place since the beginning, so for a year now, and any signal with adverse effects is quickly picked up. And also just as an infectious disease, pediatric infectious disease physician, I've cared for pediatric patients who've been hospitalized and severely ill with acute COVID and complications of COVID, something called multi-system inflammatory syndrome in children, or MISC. So having seen what COVID can do, and often in children we could not have predicted will have severe complications, I do think that not vaccinating is a risk not worth taking. So that's what I would talk about vaccines, and happy to answer any questions. And then I also had a question about Omicron and school closure. So I'm hoping that step will not be taken, obviously. The challenge with Omicron is going to be the higher risk of transmissibility compared to the Delta. And if we remember, Delta was more transmissible than the original variant. So that might be something that we just have to see how it plays out in the real world. And as a parent of young children, I am very aware of what happens with school closure. And school closures have significant adverse outcomes for children, particularly in limited resource settings. So it's not going to be, it's going to be a decision that will be carefully taken if that has to be done, but I'm hopeful that it doesn't come to it. Now with adults eligible for boosts, booster and K to 12 children eligible for the primary series. I mean, I'm hopeful that won't happen, but only time will tell. So those are some of the thoughts I had on pediatric COVID, and happy to take any questions.
Dr. Matthew, there are a number of questions in the chat, but I wanted to start out. How do you address parental concerns about vaccinating their children? I'm sure you have had a number of parents questioning the need to vaccinate their children. And what is your response to them?
Yeah, so vaccine hesitancy is not a new topic, obviously, but with COVID particularly, some of the common questions I get is, oh, these vaccines were rushed, and so how do we know this is okay? So my answer to that is, all the things that happened toward a vaccine approval happened, and none of those steps were skipped. What happened is all the resources in terms of scientific knowledge, human resources, finances, everything got pulled together to make many of these processes happen simultaneously. And so all of those safety work and everything that had to come to a point where a vaccine approval would happen, all that happened for all these vaccines. So that's one of the things that I tell families. The other thing I tell them is we now have vaccinated millions and millions of adults, and what we know is that the vaccines have been safe. There obviously have been some signals of certain adverse effects, but all of them compared to what COVID can actually do pales. So it's always beneficial to have the COVID vaccine compared to any adverse effects, which on a scale, when we do it in the scale of millions at one time, we are going to see some adverse effects pop up, but they're still quite rare. The other thing I just point out is we vaccinate children against vaccine preventable infections, and the deaths due to some of those diseases are much smaller actually currently compared to what COVID has caused. So overall, I do think that children benefit from COVID vaccines. It's not worth the risk because we cannot anticipate some of these complications.
Dr. Matthew, thank you so much for joining us today. We very much appreciate it. Thank you. We move on to Dr. Dolly Fan, who many of us know for the FAQs that he has produced for us. Dr. Fan, welcome back. And Dr. Fan will discuss vaccination efforts. He is a volunteer vaccinator, as Sandy mentioned, at a clinic in Elk Grove. Dr. Fan, could you share some of your experiences and tell us what we should be expecting?
Yeah, thank you for having me back. The COVID vaccination came out in mid-December of last year, 2020. The Pfizer vaccine, the Moderna vaccine, the J&J vaccine. By February of 2021, the COVID cases in the US plummeted. Then the Delta variant came to play, and then the cases rose. We fought back with the boosters. Then it came to the more infectious Omicron. And then we countered that with vaccinating the 12 to 16-year-old, and then now the 5 to 11-year-old. So it's this back and forth. We're not anywhere near the end of the game. By the end of 2021, the total COVID death in the US would have surpassed the ones that were all COVID death in 2020. There are a lot of challenges in vaccinating the unvaccinated. The human nature is that we're looking for certainty as safety. Unfortunately, the vaccination science does not give you 100% certainty. That opens a lot of doors for misinformation. Some of them are just lies, and no, there are no computer chips inside these injections, and they don't change your genetic material. But others are just answers we don't have. So are the vaccines more effective or less effective against different variant? We don't know the answer. What are the 5, 10, 20-year-old consequences of vaccination? We don't know. So we have to work through that. We're basically working with fear in the vaccination process. There are two types of fear. One is the fear of the disease. That's the fear that you talk about when people come to vaccination clinic. They all fear about getting COVID and getting the consequence of COVID. and then they want to protect themselves and their loved ones, so that's why they get vaccinated. The other type of fear is fear of the vaccine itself, and that opens a lot of doors for misinformation. Whether these vaccines are tested enough, whether the government manipulating data, can you trust the reporting system? Whether vaccination is the politicians and the pharmaceutical companies want to benefit themselves financially as well as politically. These are the things that you have to fight through. So talking to different people, they tend to be less specific when they come to talk about the fear of vaccination. It's a more generous, broad brush, and you have to listen to them and find out what specifics you need to address. Sometimes arguing with them is counterproductive. People believe what they want to believe. With regard to federal vaccine mandate, the government really cannot force you to get vaccinated. So they can only say that if you don't get vaccinated, schools and theaters or congregations will not allow you to come in, and they don't do business with you. So in my opinion, I think mandate is more tailored towards the local government is probably more effective. Dr. Matthews already talked about the pediatric vaccination, and then all I can add is that in the clinical trial prior to the approval of vaccinating children, there are 4,500 children aged between 5 to 11 that's been enrolled in clinical trials. And vaccines are not only safe, but they're more effective. So the side effects like soreness or headache or fevers and chills, they're mild, they go away in a few days. Even the most feared side effects of pericarditis or myocarditis, they go away after a few days anyway, so far at least. The California numbers mirrors the federal numbers. As far as I'm concerned, there are about 700,000 children in California have been infected with COVID virus. And there are 6,500 pediatric hospitalizations in California. And there are 38 deaths. So COVID virus is relatively benign to children, but they are not benign by any means. These numbers and facts, I would use those to drive vaccination in pediatric population. With regard to boosters, from what I know, people are getting the boosters, but certainly the rate of getting the boosters is slower than the primary series for many different reasons. If you just add another layer of manipulation, and you can peel away people for different reasons. I know some physicians' friends are hesitant to get the boosters, so it is a long fight. So that's what I'm going to talk about. I'll be happy to answer questions. Thank you.
Maria del Pilar Marrero has a question for you. Maria, will you ask your question?
Hi, Sunita, it's me, Pilar.
Oh,
hello. That's my full name. That's
I didn't
actually my
recognize.
full name, which I never use, but sometimes Zoom does it for me. I just wanted to ask Dr. Fan and any of the other doctors that are on the call, what else can we do as media? Because Dr. Fan, who was talking, and Dr. Wen also talked about disinformation. Sometimes we in the media are complicit in spreading disinformation. We have a responsibility to not do that, to do not repeat the disinformation, to do your research and to access experts. So Dr. Fan or Dr. Wen or anyone else, what else would help you from us in the media, from us reporters, to address the fear and the human nature that you referred to? Thank you.
The criteria for me for a good information is that it is peer reviewed. What does that mean? It means a lot of these specific high-grade scientific informations are complicated. The way that as the scientific community put out this information as truth is that it's gone through a review process. You can only guarantee the process is reviewed. Normal, good publication with a good reputation, information is coming from that, to me, is more accurate. than things spread around and not validated by peers.
Thank you.
I-
Dr. Nguyen?
Yeah, I agree with that, but I also think we have an opportunity to tell stories too. So on the one hand, when you talk about the science, you got to use the best science, and you got to be careful about a little bit of sensationalism. You know, even based on some of the questions that we're seeing even on this call today, a little thing that's coming out there seems to be more interesting than the big thing that we're looking at, right? So got to be very careful about writing stories about things that we don't quite know the answers to yet. But the other is that you can tell stories about how this pandemic is affecting our people. Those stories, I think, resonate more, and sometimes, at least in my health education work, works more than just the facts. Clearly, the facts work with lots of people, but there are people for whom the facts don't work all that well. So it's these kinds of relational communications that I think is important.
Thank you so much, Dr. Nguyen. We move on next to Peter May-Barduk. Peter is going to address the question of global vaccine equity, which has been so crucial, I think, to conversations that we have about COVID. Peter, welcome.
It's great to be with you. Thank you. Let me just start with Khalil's question, so I make sure we address it in brief, and then I'll go through and hopefully get to it in more detail. Yes, every country right now has the right under law and international rules to waive patents, authorize competition, and build its own manufacturing capacity. If it can, countries should do that, so they're untying their hands. And the few countries that are still blocking a waiver of rules at the World Trade Organization should stop. But that said, that on its own is not a pandemic solution, right? It's there, and it does not solve the problem of urgent vaccine manufacturing, which requires more inputs, investment, technology transfer, and regulatory solutions. And the timeline for some of these things is longer than we would like. So I'll try and address each of those pieces. I'm probably speaking too fast also, so I will slow down. So where we are today, there are more than 5 million deaths globally, probably between 10 to 20 million as a result of the pandemic. In other words, if you include excess mortality, not only deaths directly from COVID, but from problems induced by the pandemic, the numbers are staggeringly high. There have been more deaths from COVID after the first vaccine was introduced than before. And that's a statistic that shows us how deep the problem of vaccine inequity has been. Today, more than half the world has received a dose of some kind. And I heard the commentators earlier say, let's not use fully vaccinated. So I'm not sure what the stand-in should be, but we're approaching half the world for the now outmoded concept of fully vaccinated. Clearly massively inequitable globally. We're still at single digits of vaccination in much of sub-Saharan Africa, which is entirely intolerable and a result of a regime that I consider to be vaccine apartheid, a purposeful systemic inequity, hoarding not only of doses, but also of consumables and raw materials by the wealthy and more powerful countries that has slowed global production, and of course, a refusal to share technology on the part of some vaccine leaders that has limited abilities to scale up some technologies, and not only vaccines, but treatments and diagnostics in developing countries. COVAX, the Global Vaccine Equity Initiative backed by the World Health Organization, had a modest goal to begin with of delivering 2 billion doses to people in low and middle income countries by the end of 2021. That's a less ambitious target than many of us would like, and they're nowhere close to meeting it. Right now, COVAX is fighting to get 800 million doses out by the end of the year. And that's terrifying given that COVAX is sort of the solution we have for some kind of vaccine equity. And it's a solution we all need to support. And it's also a solution that shows that we're going to need more expansive tools. COVAX, of course, is not the only source of vaccines for low and middle income countries. China has shipped more than 1 billion doses internationally already. Maybe the number is quite a bit higher than that. I need to check back. Many from India, many from Europe. There are vaccine sales and negotiated contracts directly from those sources, and separately donations. On the donation side, the United States leads, but on total exports, to be clear, and provision of doses abroad, China leads. But however, not all vaccines are created equal. And the second level of vaccine apartheid is not just about raw access to that first dose, but the reality that poor countries are more likely to receive poor vaccines, something that is going to have increasingly serious consequences as we get deeper into the pandemic. All of this, unfortunately, sadly foreseen, and sort of underscoring the need to equip adaptable capabilities globally that can put out large-scale manufacturing of vaccines that can be adapted to variants more quickly. We see mRNA as a useful platform for that. It should not be the only one or the only tool used, but it's why some of us have worked on trying to disseminate mRNA manufacturing capacity globally, because it can be retooled, adapted to fight variants. And of course, some of those vaccines have shown extremely high efficacy rates. NIH Moderna publicly funded vaccine in its development being the most effective in the world so far. I know we have limited time, but challenges right now, delivery and distribution is a major one. And what the African Union and World Health Organization have said in light of Omicron is we need predictable supply from abroad, predictable, consistent supply, because if we had known from the beginning of the pandemic when vaccines are coming, and that we would have shipments early on, we could, of course, adapt our vaccination campaigns and public health infrastructure to rolling out those vaccines to our population. We can't expect any country to suddenly build an infrastructure and vaccination rollout late in the pandemic if we suddenly dump a large quantity of doses that are near expiration on a country. So we have to do much better than that. And I think aid agencies globally have heard this and are working on it. In the United States, the U.S. Agency for International Development is working very hard to sort of adjust its plans with colleagues and meet some of these criteria that the African Union and others are putting forward. On the manufacturing side, there are new projections underway in light of Omicron. The world could look very different depending on if indeed we need new vaccines in light of Omicron or not. If not, vaccine manufacturing is increasing exponentially, and it may be the case that in the year ahead, the problem is more one of delivery and distribution than absolute dose availability, with the caveat that we'd still have the problem of unequal access to the best vaccines. But if indeed we need to retool vaccines in light of Omicron, it's going to be very rough, because the optimistic scenario is 6 billion doses by October, no doses available before end of March, early April. And when those new doses start coming online, rich countries will buy them up again. Of course they will. And it would slow the global vaccination rollout, including access to first doses, at least of mRNA, to the extent people at that point will not have received first doses in some countries. But to be clear, I mean, I do think that governments are taking this problem seriously and working on it. They're just not putting forward all the available tools. Now, on the point of sharing technology and resilience, there are some really interesting projects underway to improve this situation, but the timeline is long. There's a technology transfer hub being set up by the World Health Organization, Afrigen, and South Africa to share mRNA technology with manufacturers all over the world, starting by copying the NIH Moderna vaccine. It's an ambitious project, low resourced at the moment, but they're getting their budget made up. Unfortunately, it will take a couple of years to bring a project like that online. Meanwhile, some of the major vaccine manufacturers are talking about installing manufacturing capacity in Africa, their own closed plants. We see that as less ideal in terms of sharing technology with humanity. But if it puts doses, but if it helps expand the availability of manufacturing and dosage in Africa, that of course is also a critically important goal. Still, the timeline a little longer than we want. Finally, there is, however, progress in this area, not only from the companies, but from government investments. The Biden administration recently announced an initiative to put 1 billion more mRNA doses in circulation by the second half of next year through urgent investments now. And it's investigating the terms and conditions by which it will do that, with which manufacturers it will operate. And we and others, of course, are aiming to inform that process. The concept of intellectual property here, the challenge is that every government has the right to overcome those challenges nationally if they want. It's a question of political will. And it's important. However, once you do that, you still need the know-how. You may need the vaccine recipe, which can be a multi-thousand page document about how to cook vaccines at scale according to the specifications that have come from the prior company. And you don't get that by waiving IP. We may still be able to compel it, and we have asked the US government to compel disclosure. However, in an ideal scenario, we actually get the companies to work with other manufacturers to move that process more quickly. Still a political question, still a question of leverage, and we have seen far too much reticence and of course, not profit motive and monopoly motive from the companies to make that happen. Now, I'm sure I need to wrap up, so I should leave it there, but just therapeutics, unfortunately, we're looking at, I think, a repeat of the same vaccine dynamic through the first 3 quarters of next year. Supply of the Pfizer drug, for example, does not look to be great enough to serve world need, and it will take until at least the second half of next year to get generics online. We're going to try to move that too, and we can talk more about it if helpful.
Just a basic question for reporters. You mentioned that we are at single digits in terms of getting the developing world vaccinated. Is that number close to about 3%? Would that, I think we've been reporting that. Is that accurate?
It's higher for low and middle income countries. For low income countries, it might still be single digits. Perhaps someone else on the call knows, but many countries have long surpassed that. It really is it's concentrated in sub-Saharan Africa that we still have countries that are in single digits in vaccination. The world as a whole, as I say, is now, depending on whether you're talking first dose or multiple doses, approaching or over the 50% mark.
Thank you. Sandy has a question for all of the speakers. What do we do about an exhausted, depleted medical care force? Dr. Fan, would you like to start that off?
Well, there's no good solution. There's no good answers to that question. I think care for the caregivers is the slogan that we've been posted up since the beginning of the pandemic. I think different organizations, different hospitals that put up different measures, rotating people through, try to have contingency plans. For example, in our institution, we have 7 levels of alert. You try to rotate as much as you can, maximize the corners as much as you can. Not being in an administrative position, I don't have a good answer to that question.
Dr.
Maybe
Nguyen?
Dr. Nguyen.
Yeah, I mean, I think on the community side, the most important thing that you can do is give us hope and reduce our workload. I mean, it's like if we have fewer cases, we would, and we're seeing people not being so resistant to the thing that we know work. That's what the rewards we need. And yes, more breaks would be very helpful, you know. But we need to help each other out. I think someone said this is all about all of us doing everything together. So,
Dr. Matthew.
I agree completely. I think vaccination is not just for the individual, but also for the community, for people who cannot be vaccinated or who cannot develop an immune response to vaccination because of an underlying condition. So there are many reasons, and I think it's everyone's duty at this point. And so that's pretty much the only thing I can say. I feel like the healthcare workers have continued to be resilient, but obviously everyone's losing steam. And so it's always helpful to have less burden on the hospital system.
We're out of time, but I have one final question for all speakers. What are you most concerned about for 2022? Dr. Matthews, since you're on, could you address that first?
Well, I'm concerned a little bit about the Omicron actually, and about what the landscape is going to look like with the vaccine effectiveness being questioned. My hope is that Omicron will just want to be this minor cold virus that will just live with us like other coronaviruses, which are cold viruses. But if not Omicron, maybe the next one, whatever is going to be the new COVID that's going to live with us. But I'm hopeful. I'm hoping that this won't result in severe illness and greater burden on the hospitals. So that would be my concern.
Peter, what about you?
Well, Omicron, of course, frustrating. The vaccination effort globally has been very slow to get started. And if we have to start from scratch, not scratch, obviously the progress has made a difference in any case. But if we need new vaccines, then we're going to be back in a similar situation. And I fear the world has not changed enough in the interim to avoid the same outcome. So, yeah.
Thank you. Dr. Wen.
My only message is get vaccinated, get masked, everyone.
Thank you. Dr. Fan.
Well, my concern actually is not about the virus itself, about the consequences it generates. School shutdowns, travel restrictions, societal consequences, other kind of diseases not being treated promptly. That would be my main concern. It's not the virus itself, but the societal consequences that the virus delivered to us. I think in 2022, that's my main concern.
Dr. Newman.
Yeah, vaccine mandates, just do it. I appropriated that intellectual property from Nike. Yeah.
Thank you. Sandy, final remarks.
It's just wonderful because I have a whole set of new ideas for stories as a result of this. And probably the first one I'm going to assign to you, Sunita, is that it's up to us to keep our healthcare workers healthy. If we don't protect ourselves, we're going to lose the whole ballpark. We're going to lose all these fantastic caregivers. I hadn't quite flipped it that way, but I think Dr. Nguyen put it very well. Give us hope and reduce our workload. It's up to us.
Thank you so much.
Thank you all. Okay.